Okay, Marfan, right? Polycystic kidney disease. That was the last one? Excellent. Okay. Pharmacogenomics and gene therapy. Those we kind of went over. Okay? So the things that are in the book still to make sure you read and look at. Chapter 13, hypercholesterolemia. 14, cardiomyopathies. 18, melanoma. And I guess 21 we kind of sort of hit on too, the ethical stuff. Okay, so those are the ones. Also remember, just like in your midterm, if it was in your text, even on things that I lectured on, it's fair game. But you guys know I'm not here to trick you, so I'm not going to find something really crazy and obscure to try to trick you up on. Okay, so even on those chapters that I didn't cover, it's big concepts, right? So disease states, what you're looking for, that type of thing. Especially like with those cardiomyopathies, some of the rhythms. You know, make sure you kind of know what are those things you're looking for with each of those types of those rhythms and stuff like that. Okay. So again, I don't expect there to be anything tricky on this. So even some of the questions I'm using from the old one, I'm rewording because I just didn't think they were as clear as I wanted them to be for you guys. Okay.
So it is cumulative?
No.
Oh, I see what you're saying now. I got you.
Yeah. Yeah, not cumulative, just from what we, after the midterm to this point. Yes.
What you talked about, the aneurysms?
Yes.
Is that a chapter?
Yes, there is a chapter, familial thoracic, which one is it? 12.
Oh, okay.
Yeah, so when I was calling out those chapters, remember, those are just the ones that I did not lecture on.
12?
I did lecture on 12.
So you said if it was on the midterm, if it wasn't on the midterm, it might be on the final, or if it was on the midterm?
You only need to know what I have covered from the after the midterm. Okay, it's not cumulative. So after the midterm to now is what is fair game for Friday. Thursday. Whenever your test is. Next week, Thursday. Okay. So you guys remember I like things like tables, information that's in tables, information that's in pictures. Those are always big things. Like for instance, in chapter 18 on melanoma, there's a table, 18.3, that's like personal history predictive for melanoma, things like that. I would recommend. When we talked about Marfan, I didn't really talk about Ehlers-Danlos and stuff like that, but those are still, because it's still in the text.
You didn't talk about what?
Ehlers-Danlos. It's like an associated similar type disease, okay? I'm not going to ask you like weird things on it, but I'm just saying that there are things that were in those that I didn't touch on. Like chapter 14, there's a nice table, 14.2, about screening guidelines for cardiomyopathy. Bless you.
Thank you.
We talked about a little bit with thoracic aneurysms. you know, about excluding Marfan and other diseases before you're diagnosed with the familial thoracic aneurysms. So things like that. In hemochromatosis, there are things we talked about, like a diagnostic criteria with serum, ferritin, and iron levels, and things like that. I think we also touched very briefly, but they talk about it more in the text, about how it affects males, usually more than females. And the phrase for that is called sex-influenced phenotype. It's in your book. Treatments for sickle cell disease. Bless you.
Thank you.
With gene therapy, I may ask you pros and cons, which I went over in class Wednesday about using viral vectors or using naked DNA. So I may hit on some of those. Pharmacogenetics, you may find questions on things like drug metabolism. And there's a section on drug metabolism on warfarin metabolism. I'd read that. Benefits of gene therapy, benefits of pharmacogenomics. Diagnostic criteria for Marfan. Okay. Everybody good? Okay. Okay, I think I've weeded out old stuff that I didn't really like. Any general questions? No? Okay. As far as your grades go, everybody knows what they got on their midterm. Dr. Anderson has talked to Karis about that other test question. So check your grades. If nothing has changed, which it should in the next day or two, okay, so let Dr. Knudsen know. And she will circle back around again on that topic. The other piece of your grade is participation, and I think everybody has participated, been active and involved, and I appreciate that because I don't want to stand up here and talk to chairs all day. So thank you very much for being interactive. All right. Are we ready? Yeah. Okay, so I have 3 musketeers and flip pops. Allison's already moving over. She's like, I am getting on the edge.
All right, you guys ready? Okay, some of these are gonna be tough because we didn't cover all these. I don't know if you've read them all well. I'm gonna read you guys 4 diseases, and you guys tell me which one is autosomal dominant. Hemophilia B, sickle cell anemia, familial hypercholesterolemia, and Marfan. Hypercholesterolemia. Yay! Who said it first?
Me?
What do you want?
I did say herbs. Are those gluten free? Yes. Okay, thank you.
All right. Okay. You're in clinic and you see a baby who comes in with rhinitis, sinusitis, and birth weight at the 10th percentile. Kind of failure to thrive. 2 months old. What might they have?
Cystic fibrosis.
What would you like?
What are you saying?
Cystic fibrosis. Okay, helpful hint, in the cardiomyopathy, I would read up on Wolff Parkinson White and ARVD, the the arrhythmogenic right ventricular dysplasia cardiomyopathy. And I cannot say that again, don't ask. ARVD.
VD? Oh, VD.
Not STDs, VD,
Oh,
heart.
I don't understand.
Okay. Please, it's in the book.
I have those all right on the back. I didn't write it here.
Okay, and I know we did mention this one in class. Sickle cell anemia has a mutation that makes the protein have a new function, right? What is that type of mutation called? No? You can have a point mutation that causes a deletion, that causes a change in the amino acid. This changes the function.
Is it a frame shift?
Close. Novel property mutation.
Oh,
Not even close. It's okay, it's been a long time since we went over that.
Well, that was
What is the most common lethal autosomal recessive disease? The most lethal. CF.
Cystic fibrosis.
You have a disease where both parents are carriers. What is the chance their offspring?
25.
You said it first. Back there. What you want?
Oh, you said.
No,
Friday.
It's true, it's true.
Me either, Sean. Don't worry about it.
It's okay, Don, I'm happy.
They're going. Still.
So,
Right now.
what is the disease that having sickle cell trait,
Malaria.
malaria. So having sickle, the answer is not strawberry blood clot.
Oh, what sickle cell trait protects you against?
Yes, what does sickle cell trait protect you from? Somebody say malaria first.
It's the blood clot. Ma'am, please. I wouldn't give it to you. Thank you very much. And I like to see my name.
Okay. All right, so this is an interesting concept, and we touched on it, but I don't know if we actually use this phrase. I know it's one of the phrases in the book. So when you have this protection with sickle cell trait, from a genetic standpoint, so you're heterozygous, right? You're not homozygous. From a genetic standpoint, what is that called? When you have this protection because you're heterozygous. Okay, heterozygote advantage.
Yeah, you spelled it.
It seems so obvious when you say it.
I know. No. Okay, if you very rapidly metabolize a drug, does it work better or worse?
Worse.
Excellent. That's like a big deal. What do you want? Lollipop? Okay. I think the book also talks about like metabolism. I mentioned warfarin, but it also talks about metabolism and codeine as another big pharmacogenetic issue. Somebody give me a pro of using a viral vector for gene therapy.
It affects everybody.
What do you like?
It affects none of us.
Somebody give me another one. It's not cheap.
Easy, produce.
Viruses are, they're actually not that easy to produce. The naked DNA is easy to produce.
Other methods.
Nope. Control what better?
Control it at
Nope.
targets.
Nope. Does it integrate in the DNA or not?
Yeah.
Yes. That's another big pro, right? If you need something, if you're trying to replace a defective gene, the integration is pretty important. How about naked DNA? Somebody give me a pro for using naked DNA for gene therapy. Easy. Haha, somebody's listening. So naked DNA is easier to grow up, right? Because you're just growing it in big vats of E. coli. So you can get a lot of that naked DNA very quickly, which also makes it, that part of it, cheap. So growing the naked DNA is cheap. So getting the naked DNA is cheap. How you actually transfect cells with it may not be, but that part of it is. What is a negative?
Recombination.
Okay.
Come on.
There's no recombination with naked DNA.
It was helping.
What is a con of using naked DNA for gene therapy? Potentially a con, depends on how you want, what you're looking for.
Patient's immune system.
Pardon?
Patient's immune system could reject it.
Nope, doesn't reject naked DNA.
Is it easily damaged?
It doesn't
Usually gets into
get
cells.
into every cell.
Nope, naked DNA you can put into every cell.
Is it easily damaged because it's not coiled?
Nope. Pretty hardy little suckers.
Is it hard to dictate where it goes? Place?
So that's a good, you're almost there. Naked DNA does not integrate into
not a-
human DNA.
Low level of expression.
Right. So transient expression, okay guys? Transient expression, because it does not integrate into the DNA. So it's made briefly for a couple of days, and then it gets kicked out. What would you like?
Let's see.
Okay, so some pros of using viral vectors are integration. I mean, that's the absolute biggest one. Integration. Cons. You don't necessarily know where it's going to integrate, right? So it could integrate into a proto-oncogene and make it an oncogene, right? It could integrate somewhere that turns on a promoter region, makes up an oncogene. Just like we talked about with epigenetics, something could sit down somewhere, turn something on, and now we got a problem. So that's a big con. Depending on the type of virus, sometimes they only will infect dividing cells. Dividing cells. So, a lot of our cells are pretty stable. They're not rapidly dividing. So to use it in vivo sometimes is tough. Naked DNA, easy to produce. And it's cheap to produce the DNA. Cells do not have to be dividing to uptake the DNA.
What yields faster result?
Doesn't either one, because as long as it gets in, it gets in. Pro in some respects can be the fact that it does not integrate. Because for instance, like with what I was doing with the interleukin 12, if we had permanently turned on that level of expression of interleukin 12, what would you get?
Autoimmune diseases.
You'd get an autoimmune disease, right? Because you are upregulating the heck out of T cells and natural killer cells. So it can be a pro, depending on what you're trying to accomplish, that doesn't integrate. But it can also be a con. For instance, if you're trying to replace the gene that causes SCID in babies, right? Or cystic fibrosis, you're trying to replace that CFTR gene, you're going to get about 3 to 7 days worth of help. And that's it. So that part can be a pro and a con. Okay. Make sure when you look at like the familial thoracic aneurysms and stuff, some of the other physical findings for those patients. Somebody tell me a couple of other things that go along with cystic fibrosis. What other types of?
Pancreatitis.
Hold on. Who said pancreatitis? Oh, you really? Absolutely. I know. Sorry. Who said infertility? What else?
Mucus secretions. All the respiratory infections.
Pneumonia. Before or after bacterial infection.
What else is involved in the pancreas? Diabetes. Diabetes. Fine, sure.
Reduce bile production.
Okay.
Can I get a green one?
A green one? You like green apple pie? Okay. What are the 4 P's with suspected aneurysm dissection?
Pain, pallor, poikilothermia, and paralysis, or paresthesias.
Pallor is pulseless.
Yeah, pallor is
No,
Pallor is
That's all
pulseless.
I need.
So I thought you were pale because it's pulseless,
Yeah.
doesn't pump the blood to the same.
all of
Thank
them.
you.
That's how we learned it.
That's how we learned it.
That's
Well,
compartment.
the book is different. Yeah.
Okay, pain, pulselessness, poikilothermia, paralysis, or paresthesias.
It's paresthesias, paralysis, pallor, and pain. No, pulselessness, sorry, not pain. Pulselessness. Okay, you guys ready? Pulselessness, pallor, paresthesias, and paralysis.
Oh, pain.
Nope, nope. Not this one.
For an aneurysm?
For the dissection of thoracic aneurysm.
Oh, I thought it was
Bless you. What's the main drug used to treat right now sickle cell?
Bacteria.
I was just being polite.
I know. Who said ever here first?
I think I did, but you can go to somebody else out here.
All right, somebody haven't given something too. Somebody over here. Somebody over here said something. There you go. What would you like? It's true though. What is, and I talked about this in class, so this may not be in your book. What is the term for changing the envelope around a virus so that it infects more cells? Pseudotyping. 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 That is changing the outside envelope around a virus so that you can increase infection in cells. One more explanation of that is the fact that a lot of these viruses don't necessarily infect humans, right? We're using stuff a lot of times, those inner guts of a virus, that infects other creatures. So, but we need that virus to actually infect human cells to get it in there. So what we'll do is they'll take the outside, the envelope, from viruses that will infect other animals. Like I used gibbon monkeys. It was a GABA, something like that. Okay, so that's called pseudotyping, when you change the outside envelope for a virus. All right, guys, what is a younger patient who presents with thoracic aortic dissection? What are they more likely to accidentally be diagnosed with? No, not Marfan. We're talking in the ED. Somebody comes in with chest pain, they're young.
Musculoskeletal.
Guys, I mean immediately, somebody's pleurisy, guys. Way more likely for a young person coming in with chest pain to think they've got pneumonia, pleurisy, bronchitis, until they get the x-ray. What is that physical finding on x-ray, the big bump, called? It's aortic knob. So if somebody's got an aneurysm, right, around the sinuses, it looks like an aortic knob on chest x-ray. Make sure you go over in sickle cell some of those diagnostic, like I said, the serum levels and blah, blah, blah. But also remember, when you do blood work on them, you're looking at prothrombin times and, you know, some of those things. So think about the PTTs and the PT, what kind of levels? Are they elevated? Are they not? Bleeding times, stuff like that. It's pretty specific. I think I talked about it, and it's also in the book. For sickle cell. Okay? Okay. Hereditary hemochromatosis. What's your best treatment choice for those patients? Phlebotomy. What would you like? Back there too? Respiratory. I'm coming back there with yours too.
I get those.
What would you like? All right. All right. I know it's 10 till. Do you guys want a break, or you guys want to be done and go study?
Power through.
Okay.
No break.
Last questions. Anybody have last questions for me?
Thank you.
You're welcome. Thank you, guys. Okay.
Do you know when we do our review, if the credit will go to Anderson or Keel?
It's very important because we're writing some reviews.
It's okay, I wrote, she did not, I said Dr.
I don't know. That's a good question
The
because
numerical rating goes to Anderson, and then in your comments.
Okay, so 0.
So I wanted to
So,
make sure.
and the 9-year-old
Is
not
there
just
a
a course.
Okay, wait, you know what, I will ask this of Dr. Knudsen, because when I taught at FGCU, I know as a professor, it's actually really important to be able to hang on to your evaluations and show them. So I will find that out, because,
She doesn't even have Yeah.
I really don't want to get
more, and we don't wanna hurt you.
thank you, I really appreciate that very
Subtle.
much. Yeah, I'll find that out, but I appreciate it. I've had a lot of fun, thank
I don't
you,
wanna
I
give
really
Anderson a
appreciate you
bunch of
guys letting me.
fives.
And I will be available, you guys still all have my email, so even after class is over, after, after the test and everything, so email me if you have questions, first of all, about the exam. But, afterwards, I'm available to you guys too, whatever, if you ever need anything, you guys can reach me, so. I'm gonna leave this up here because I'm on a no-carb diet and I got a diabetic kid, so you guys enjoy for studying.
Ashley.